cultural variations and ethical dilemmas in the pediatric population of England. Everybody today is familiar with the anti-vaccine Karens of the United States and the havoc they have caused in recent years. How we have seen conditions and diseases once thought nearly eradicated come back to the forefront of modern civil society. But are we alone? In this presentation, we will examine the healthcare system and practices of England in the UK and take a closer look at some possible ethical dilemmas concerned with the pediatric population of that country. First, as we take a survey of the healthcare system in England, we notice that it is very different from that in the United States. In the US, our healthcare system is largely made up of private insurance. However, in England, they have a publicly funded system called the National Health Service, or NHS. It was founded in 1948 and is primarily funded through central taxation and remains free at the point of care for the UK population, apart from the charges for adults for prescriptions, optical, and dental services. In contrast, the healthcare in the US is delivered mostly exclusively by private sector providers and comes with quite a hefty price tag. Most children in England use the state-funded NHS for all their healthcare needs. The vaccine schedule in England at first glance is very similar to that of the United States. All vaccines are voluntary, but parents are strongly advised to encouraged to follow the routine vaccine program. Social media has made it hard for public health services to quantify the influence of anti-vaccine propaganda. The Strategic Advisory Group of Experts on Immunizations Vaccine Hesitancy Work Group has defined vaccine hesitancy as a behavior influenced by a number of factors, including issues of confidence, competency, and convenience. Vaccine hesitancy should be applied to those parents whose conscious deliberations demonstrate something akin to indecision. By this definition, anti-vaxxer is not vaccine hesitant. They are outright refusing the vaccines. Would there be a time where the provider could override the parents or guardian if there are no medically relevant reasons as to why the minor child should not have the vaccine? Could the provider simply give the vaccine anyway? This poses a very important ethical dilemma, wherein a pediatric patient who by law does not have a voice in their care having medical decisions being made for them by someone who willfully rejects scientific data. The principle of non-malfeasance asks us not to intentionally or unintentionally inflict harm on others. We should not cause unnecessary injury or harm to those in our care. Non-malfeasance is the bedrock precept of countless codes of professional conduct. By this principle, a care provider can make the best decision for the patient, but patients have autonomy, which is a rational capacity for self-governance and self-determination, and must consent to procedures. However, one could argue that when it comes to a minor child, one could raise the issue of paternalism, which is the overriding of a person's actions or decision making for his own good, When it comes to the minor child, this falls back on the parents or guardian. They have the authority to make medical decisions for their child. However, one could argue that an anti-vaccination parent does not have their child's best interests in mind while making these decisions, and therefore the decision should revert to the primary care physician. Coverage for the MMR vaccine peaked at 92.7% in 2013 and 14, following a decreasing to around 80% in the early 2000s. Trends in vaccine confidence based on the Public Health England attitudinal survey and vaccine coverage during the same time period suggests that the decline in vaccine coverage was preceded by an increase in vaccine confidence and a decrease in the proportion of the parents encountering anti-vaccination materials. Due to the nature of social media, studies find it hard to truly quantify the size and influence of online anti-vaccination movements. While none of these analyses in isolation constitute high-grade evidence, when considered collectively, they do make a compelling case. However, there does appear to be an overwhelming evidence that vaccines, when used appropriately, can make an enormous difference in the community. For example, the inclusion of the Hib vaccine program led to a 98% decline in the incidence of invasive Hib infections, and there have been no deaths due to this invasive Hib disease in children in England and Wales since 2011. The incidence of tetanus has also remained low, and the majority of cases occurring in England are in older adults who have not received the recommended vaccine program. In conclusion, this research has concentrated primarily on evidence from England. It gives the appearance that the anti-vax movements are not as prevalent as they would be in the United States. Vaccination, especially in childhood, is recognized globally as one of the most important healthcare interventions. The evidence is there, but many choose not to acknowledge it. At what point should pediatric patients have a say in their care? Do they deserve the same autonomy as older adults? Or where do we draw the line between a mother knows best and child abuse? These are some of the ethical dilemmas that plague healthcare not only in the US but in the UK as well. A dilemma that will require much more deliberation and studies to be conducted before a determination can be made.